Good afternoon. I would like to thank the Society for giving me the opportunity to communicate with you during these extraordinary times, and thank you for attending this clinically relevant session. As you all know, denosumab is a human antibody to RANG ligand, which is used among others in the treatment of osteoporosis. When given by a subcutaneous injection, we see that very rapidly it decreases bone resorption, measured here with the bone marker serum CTX. This is a rapid and profound decrease of bone resorption. At the same time, there is an increase in the levels of the antibody in the circulation, which start declining slowly as the antibody is eliminated by the reticuloendothelial system until about 5 or 6 months later, when it starts disappearing from the circulation. Concurrently with the disappearance of the antibody from the circulation, bone resorption starts coming up again, as shown here, and this is the reason, of course, for using one subcutaneous injection every 6 months. But this shows us at the same time how quickly bone resorption takes off again when the antibody disappears from the circulation. This has been shown in numerous studies, and this is one of the very early studies where denosumab, one subcutaneous injection every 6 months, was compared to placebo over 2 years in women with osteoporosis. And as you can see, after 2 years, when treatment was stopped, there was a rapid increase in the rate of bone resorption. Actually, within 6 months after stopping, it went up, and after 3 months and at 6 months, reached this highest point, and then it started coming down until about 2 years later, when it reached the basal levels. Now, as you can see here, the increase in bone resorption exceeded that of the placebo-treated patients and even basal levels. And this is what is usually called the rebound phenomenon. The result of these changes is the rapid decrease of the gain bone mineral density as it occurs with all other anti-osteoporotic treatments, except, of course, the bisphosphonates. As you can see here, you lose much more bone. These are from different studies, of course, but you can appreciate the rapid loss of bone with denosumab compared to other treatments. At the same time, you see the maintenance of the gain when you stop a bisphosphonate such as zoledronate or alendronate, and this is what allows some people to consider the so-called drug holiday in the management of osteoporosis. This concept, of course, is impossible with every other treatment, and particularly with denosumab. But these are results 1 year after stopping from the lumbar spine BMD. However, the same result is also obtained when you measure the BMD at the hip, and we see that when in a phase 2 study, denosumab given for 8 years or for 4 years, and then treatment is stopped, the magnitude of the decrease of bone mineral density was the same in both groups, independently whether one had received 8 years of treatment, whereas the other 4 years of treatment. In 2016, a number of case reports reported at the same time a new clinical observation, namely the appearance of multiple clinical vertebral fractures in patients discontinuing denosumab treatment. In an analysis of the first cases, Anastasilakis and colleagues looked at the characteristics of these patients, and their age was 64, so there was nothing strange in all these. The time of the appearance of the symptoms was 8 to 6 months after the last denosumab injection, so it appeared to occur very early after the time that the patient was supposed to have a new injection. 1/3 of the patients had prevalent vertebral fractures, and most importantly, all those described, nearly all of those described had multiple vertebral fractures. 22 out of the 24 had sustained multiple vertebral fractures, whereas there were no non-vertebral fractures. The location in the spine was typical for other osteoporotic vertebral fractures. So this raised a number of questions regarding both the frequency and the pathogenesis of this event. And people looked at data that had been obtained during the Freedom study and its extension, and they looked specifically at patients who had stopped treatment in this big osteoporosis trial with denosumab. And as you can see, and as we all know, during treatment, denosumab reduced the incidence of vertebral fractures greatly, and also in the group of patients with at the highest risk, namely those with prior vertebral fractures, as you can see here. However, when treatment was stopped, either placebo or denosumab, the incidence of new vertebral fractures was very similar between patients who had received placebo and those who had received denosumab. In other words, it went up to the baseline, the risk to the baseline level, and this was also the case in patients with prior vertebral fractures. The second question that this study addressed was the frequency of multiple vertebral fractures in those stopping denosumab. And as we can see here, this is now looking at the incidence of these fractures. We see that those discontinuing denosumab was about 6%, but the majority of them were multiple vertebral fractures, contrasting the findings of the placebo-treated patients. And the same was also the case in patients who had prior vertebral fractures, and you can appreciate that also here the majority was sustained multiple vertebral fractures. Up until now, we don't have a clear pathogenetic explanation for these type of fractures. Why first some patients do suffer these fractures, and why. There are various theories and hypotheses which we can discuss later on, perhaps. Now, so when they looked at potential predictors of this response, the only clear risk factors that came out from this analysis was that the presence of a prior vertebral fracture increased significantly the risk of new vertebral fractures after discontinuation of treatment. And as you can see, this was for any vertebral fractures, and more importantly, for multiple vertebral fractures. Otherwise, the others showed no important differences. And I would like also to stress that of those who showed no significance, we see here that duration of treatment was not a risk factor for vertebral fractures following discontinuation of denosumab. So, all these results made absolutely clear that if for any reason denosumab should be stopped, we have to take measures. The best is, of course, to continue denosumab. As you can see here, and as we know, continuing denosumab treatment for up to 10 years is associated with levels of bone turnover which are very low, and these are associated with progressive increases and continuous increases in bone mineral densities, even at the hip, and at the same time there is a reduction in the incidence of fractures which continues during the 10 years of treatment. However, if for any other reason it's impossible to continue with denosumab, then we have to choose another anti-osteoporotic treatment. Choosing teriparatide is definitely wrong and should never be done alone. If you want to give teriparatide, you have to do it together with continuing denosumab. The reason is that you lose more bone, and I'll give you just an example from the data switch study where you can see, if you follow the red line, these were patients who were treated with denosumab for 2 years, and then they received teriparatide, and you can see the tremendous bone loss following the administration of teriparatide. Therefore, the current view today is that discontinuation of denosumab should be followed by treatment with an anti-resorptive, and bisphosphonates are the preferred agents to do that. There have been numerous small studies or case series examining the effect of different bisphosphonates after stopping denosumab, and these have produced variable results, some showing maintenance of the effect, others showing great loss. But the first controlled study was done with weekly alendronate. This was a study that was done in women with osteoporosis to examine the persistence of the two treatments in these. Was not done specifically to examine the effect of alendronate upon discontinuation of denosumab. And you can see here, after 1 year of denosumab treatment, there's an increase in bone mineral density, and when this is followed by 1 year of weekly alendronate, we can see that the level of BMD at both sides was maintained. Together with our Greek colleagues, we reported the first prospective study of discontinuation of denosumab followed by bisphosphonate treatment at the end of last year. This was a 2-year parallel assignment, open-label, multi-center randomized efficacy study in which treatment-naive women older than 50 years with postmenopausal osteoporosis received injection of denosumab every 6 months and achieved non-osteoporotic BMD scores at the hip and the spine. And these were randomized. And either to continue denosumab or to receive a single intravenous infusion of 5 milligrams zoledronate. This is shown graphically here. The patients had osteoporosis, had not received any other treatment, were given denosumab. When they reached osteopenia, they were randomized to a single infusion of zoledronate, or they received another 2 injections of denosumab, and they were followed up to 2 years. When we look at the characteristics of the study women, there were no significant differences among them, and I would like to also to point out that they had both groups severe osteoporosis. You can see the high frequency of prevalent vertebral fractures among them. At the same time, you can see here the osteopenic levels of BMD they had achieved. Now, this shows the changes in bone turnover markers with the two agents. First, after the infusion of zoledronate, we see that the low levels of bone markers, either P1NP or CTX, are maintained. There is a small increase within the normal range, which is to be expected because zoledronate is less potent than denosumab, shown here, and these levels are being constant up until 2 years of treatment. In contrast, denosumab given here for 6 months, 2 injections at 0 and 6 months. Here was the time the patient was supposed to get a new injection, which was not given, and we can see that very quickly after this point, and in fact 3 months later, so 9 months after the last injection, there was a rapid increase of markers which picked up at 6 months. So a type of response identical to what we have seen previously with denosumab. Importantly, when we looked at the changes in bone mineral density, we can see that treatment with zoledronate was able to maintain the gains obtained earlier with denosumab, both at the spine and at the hip at 2 years, whereas those who stopped denosumab did lose bone quite rapidly, and of course the difference between the two groups was highly significant. What about vertebral fractures over this period? There was one patient who received zoledronate who had a vertebral fracture after 12 months, and 3 with treated in the group with denosumab, of whom 2 had multiple clinical vertebral fracture, so an incidence of about 7%, which is remarkably similar to the previous study. So I think from what we see in the previous, we can conclude that these must be the real incidence of these fractures, serious fractures, but low incidence. When we look at the individual responses of BMD, the individual BMD responses, and here we look at lumbar spine BMD after a single infusion of zoledronate at 1 year and at 2 years, we can see there's a great variability in this response. The interrupted lines represent the least significant changes as defined by the International Osteoporosis Foundation and the National Osteoporosis Foundation. And you can see there's responses, as I said, variable. However, after 1 year, all patients examined maintained the gains of BMD. However, after the second year, there were 3 patients which escaped. So this tells us that the patients should be followed at yearly intervals. We had the opportunity to look at the group of treated with zoledronate for an extra year, and these are the results obtained over 3 years of observation. And as shown here, in the lumbar spine, there was the increase we saw before, and then a progressive decrease over 3 years. However, this point was not significantly different from the point at 2 years or from the baseline. So there was a drop, however, it was not a dramatic drop. And when we looked at the changes at the femoral neck, there is absolutely no change. So in other words, the zoledronate in this group of patients was able to maintain the gain of BMD in the majority of patients for a whole period of 3 years. And these patients were given no other treatment. In fact, at the end of the 3-year period, only 20% of the patients had returned to osteoporotic values. In other words, 4 out of 5 patients given a zoledronate infusion remained osteopenic after 3 years. In contrast to that, to these results, a recently published study, a Danish study, showed a very different picture. These were women again with osteoporosis treated with denosumab who were given different ways, who were given zoledronate in different ways. For example, 6 months after the last denosumab injection, so identical to our protocol shown here in red, or 9 months after the injection, this is the green, or another way, where patients were picked depending on changes in BMD or their bone markers. And I would like only to concentrate in the arm of 20 patients, which was similar to what we presented. And as you can see here, this group already at 1 year had lost a mean of about 5% at the lumbar spine and close to 3% at the femoral neck. Therefore, results that are very different from the ones we reported. In addition, the authors reported that the majority of patients, namely 65% of those studied and given zoledronate, failed to maintain their BMD at 12 months. Obviously, these raised a number of questions, and first we looked at potential differences in the characteristic of patients between the two studies. And when we look first at patient selection, our study included only postmenopausal women with osteoporosis. The Danish study had women and men. Of course, men represented only a very small proportion of studied patients. Importantly, our patients were treatment naive, whereas nearly all patients in the Danish study had received previously bisphosphonates, the majority of them alendronate, and this is a little bit strange because it has also been suggested from open studies that if a patient had received a bisphosphonate and also denosumab and then stopped denosumab, this previous treatment with bisphosphonate might slow down the bone loss. And here we see that it was definitely not the case. And another potentially important difference is that in our study, our patients had received denosumab for a mean period of 2.4 years, from 1 to 4 years, whereas the treatment, the denosumab treatment, the period of denosumab treatment in the Danish study was much longer, a mean 5.2 years, with a range between 2 and 7 years. Is this perhaps the reason of the differences? Has anything to do with the bisphosphonates? Is there anything else? These are issues we still do not have answers. Now, to summarize and conclude, cessation of denosumab treatment is followed by rapid reversal of its favorable skeletal effects associated in a few patients with vertebral fractures, about between 6 and 7%, and these fractures, however, are mainly multiple. These events are attributable to the so-called rebound phenomenon. However, the magnitude of bone loss or the fractures themselves are not associated with levels of bone markers. This has been shown in the larger study, but also we examined these in detail in our own study, and we couldn't find any associations. Thirdly, the presence of the prevalent vertebral fractures is the strongest risk factor of incident vertebral fractures following discontinuation of treatment. Therefore, the contribution of other potential risk factors, including previous use of bisphosphonates, needs further evaluation in order to form a clearer picture. So, what do we do? If denosumab therapy cannot be continued, bisphosphonate should be given. The best option, as I said, is to continue denosumab. If you can't do this, you should give a bisphosphonate. You should give the bisphosphonate at 6 months after the last denosumab injection, because it has been observed that already from the 7th month these vertebral fractures can occur. Now, a single infusion of zoledronate consolidates and maintains the BMD gains for longer period of time in treatment-naive women with postmenopausal osteoporosis who became osteopenic with denosumab therapy given for up to 4 years. And this is what our study showed, up to 3 years. However, the effect of zoledronate in osteoporotic patients with different characteristics or longer exposure to denosumab requires further investigation, and we cannot at present recommend this type of treatment for this type of present. With this, I would like to thank you for attending this session, and I hope to be able to answer your questions during the discussion.